Welcome to the official GlobalRPh YouTube channel. If you haven't already, hit that subscribe button to stay updated with our latest videos. Whether you're looking for medical insights, the latest healthcare trends, or fun educational content, there's something here for you. This video looks at the difficulties in diagnosing low platelet counts. It highlights immune thrombocytopenia, also known as ITP, and discusses distinguishing it from other causes of thrombocytopenia. Through a review of current evidence and expert guidance, it emphasizes the importance of a systematic approach that integrates clinical history, physical examination, and targeted laboratory testing. It highlights important clinical features that can support or dispute an ITP diagnosis. This helps healthcare providers steer clear of typical diagnostic errors. Thrombocytopenia occurs when platelet counts drop below 150,000 per microliter. It is often seen in clinical settings and can result from various underlying conditions. Among these, immune thrombocytopenia, or ITP, is a significant consideration, but one that is reached only after excluding other potential causes. This video aims to guide clinicians through the diagnostic process, helping them recognize when a low platelet count is likely due to ITP, and when alternative explanations should be pursued. Three main physiological pathways can lead to a low platelet count. In some cases, the bone marrow fails to produce enough platelets. In others, platelets are produced but destroyed prematurely. Another option is that platelets may be distributed abnormally or trapped, often in a larger spleen. ITP falls under increased destruction. Here, autoantibodies wrongly attack platelets, causing them to be cleared from the blood faster. Many other conditions can affect platelet levels through similar or overlapping mechanisms. A thorough clinical history is the first step in evaluating thrombocytopenia. Clinicians should ask about the timing and progression of symptoms, recent infections, current or recent use of medications and supplements, and whether there is a family history of bleeding disorders. Travel history can offer clues about infections. Also, it's important to check alcohol use, since too much can hurt platelet production. For women of reproductive age, it is also important to determine pregnancy status. A detailed physical examination can offer additional diagnostic clues. Signs of bleeding, such as petechiae, purpura, or unexplained bruising, may be present. Swollen lymph nodes, liver, or spleen may indicate systemic illnesses or hematologic malignancies. Constitutional symptoms like fever or night sweats may point toward more serious underlying pathology. Laboratory evaluation begins with a complete blood count, or CBC, and peripheral blood smear. These tests offer vital information on platelet counts and the appearance of red and white blood cells. This helps in spotting bone marrow disorders or microangiopathic conditions. Liver and kidney tests are important. Coagulation studies, like prothrombin time and activated partial thromboplastin time, are essential too. If there is a clinical suspicion, doctors may need to test for HIV, hepatitis B and C, and autoimmune markers like anti-nuclear antibodies. A bone marrow biopsy might be needed in some cases, especially in older adults or with other issues. ITP is primarily a diagnosis of exclusion. Certain features make this diagnosis more likely. These include an isolated low platelet count with otherwise normal red and white blood cell counts, no significant findings on physical examination besides possible bleeding signs, and no clear alternative cause identified through history or basic laboratory tests. It's key to note that as many as 60% of people with ITP do not have symptoms at diagnosis. Several red flags should prompt clinicians to consider other diagnoses. Suppose the patient shows abnormalities in other blood cells, such as anemia or leukopenia. In that case, it indicates a more extensive issue with the bone marrow. It's rare to see a significant increase in liver or spleen size with ITP. This could indicate hematologic malignancies, chronic liver disease, or other systemic issues. Constitutional symptoms, such as fever, weight loss, or night sweats may also indicate a more serious underlying illness. A family history of thrombocytopenia raises the possibility of inherited platelet disorders. Certain medications, especially recent exposure to heparin, may be culprits. Unusual findings on a peripheral blood smear, like schistocytes, blasts, or dysplastic changes, should lead to more investigation. When platelet production fails, it can be due to problems in the bone marrow. Common causes are conditions like aplastic anemia and myelodysplastic syndromes. Nutritional deficiencies in vitamin B12 or folate, as well as chronic viral infections such as HIV and hepatitis C, can also affect production. Alcohol abuse is another important factor, as it can suppress bone marrow function. Increased platelet destruction may be drug-induced or due to thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, or autoimmune disorders like antiphospholipid syndrome. Abnormal platelet distribution often occurs in the context of hypersplenism. Gestational thrombocytopenia is a common and usually harmless condition. It can occur during pregnancy, and it usually goes away after delivery. A peripheral blood smear is a valuable and accessible test for checking thrombocytopenia. It helps doctors evaluate platelet levels effectively. It confirms the platelet count and can also show size or shape abnormalities. These changes may suggest specific diagnoses, such as thrombotic thrombocytopenic purpura or myelodysplastic syndromes. Patient age is another helpful clue. Immune thrombocytopenic purpura is common in young adults and older people. In children, it usually follows a self-limited viral illness. Clinicians should remain vigilant for drug-induced thrombocytopenia, especially in patients on multiple medications. Mild thrombocytopenia often occurs in pregnant women during the third trimester. It usually goes away after childbirth. In older adults, do not diagnose chronic immune thrombocytopenic purpura without a bone marrow exam. This helps rule out conditions like myelodysplastic syndrome. Several factors make the diagnosis of thrombocytopenia particularly challenging. The extensive range of potential etiologies can sometimes be overwhelming to navigate. Mild to moderate cases are often asymptomatic, which leads to delayed recognition. Furthermore, there is no single definitive test for ITP. Multiple conditions may contribute simultaneously in some patients, and that really complicates the clinical picture. Research is working to improve the diagnostic process for ITP and to better understand the causes of thrombocytopenia. Better biomarkers and diagnostic tools could help find the right treatments faster and spot specific causes earlier. Accurate diagnosis of thrombocytopenia requires a methodical and comprehensive approach. By carefully gathering patient history, performing a thorough physical examination, and selecting appropriate laboratory investigations, clinicians can better distinguish ITP from other causes. Be aware of red flags and consider many possible diagnoses. This is crucial to avoid misdiagnosis. This video covers diagnostic strategies that assist in clinical decision-making. They aim to enhance outcomes for patients with low platelet counts. Question 1. How low does the platelet count need to be to diagnose ITP? Despite no strict threshold, ITP is usually considered when platelet levels fall below 100,000 per microliter. However, the diagnosis is not made based on platelet count alone. It requires the exclusion of other causes. Question 2. Can ITP develop suddenly, or is it always a gradual process? ITP may present acutely or develop gradually over time. Some patients experience a rapid drop in platelet count, while others show a more progressive decline. Question 3. Is a bone marrow biopsy always necessary to diagnose ITP? Not necessarily. Most patients don't need a biopsy. However, they may need one if they are older, have unusual findings, or worry about another bone marrow disorder. Question 4. Can viral infections cause thrombocytopenia that mimics ITP? Many viral infections can temporarily lower platelet count, making them look like ITP. This highlights the importance of detailed history taking and close follow-up. Question 5. How often should platelet counts be monitored in a patient with suspected ITP? Monitoring should be individualized based on the severity of thrombocytopenia and the patient's symptoms. In stable cases, checkups every few weeks might work. However, for more severe or symptomatic patients, assessments should happen more often, especially when treatment changes. Thanks for watching our GlobalRPh production. If you enjoyed the video and found it helpful, don't forget to smash that like button and subscribe to our brand new YouTube channel. We're bringing you a dynamic mix of content across a variety of topics, so there's always something fresh, engaging, and insightful just for you. Your support means the world to us. It helps us grow and keep delivering exciting, high-value content. Stay tuned, because the best is yet to come.